And next is I welcome Dr. Gargi Sathish to speak on unfolding the mystery of special strabismus.
Okay, good afternoon all. Thank you so much Vijayamma madam. Going straight to the topic about special strabismus types, I will just rush through just our favorite types. So the favorite of everyone will be the Duane because it is very easy to diagnose. Even my JR1s are very happy to see a Duane's because they can easily diagnose the condition. But it has its own intricacies. It comes under the congenital cranial disinnervation disorders. Most cases of Duane's are sporadic, they are unilateral usually, and somehow is seen slightly more in female children. Video. Okay, so this is a case of classic type 1 Duane, and somehow during the embryonal stage there occurred a problem, and there is a paradoxical innervation of the lateral rectus by the oculomotor nerve, and there is limitation of abduction and the classic co-contraction of LR and MR causing globe retraction and narrowing of palpebral aperture on adduction. So this is a Huber's classification. There are lots of classification, but Huber's based on EMG is what is usually said. This is type 1 Duane, which can be ortho or ESO in the primary position. Now type 2 Duane is very rare, but it still can occur. So you can see in that picture that the right eye is not abducting well. It can abduct nearly fully, but that globe retraction and narrowing of aperture in adduction will remain the same. Also in Duane 3, there will be restriction of both adduction and abduction as seen in the left eye of that patient. The globe retraction and narrowing of palpebral aperture will definitely remain on attempted adduction. Bilateral Duane's is again very rare. It's actually quite a crippling condition when you have, with regards to our binocular field of vision, because there is restricted abduction in both sides. But thankfully it is quite a rare condition. Abnormal head posture very commonly seen, especially if it is a unilateral type of Duane's, and there will be face turn to maintain binocular single vision, and in such cases amblyopia is rare because BSV is maintained. The major cosmetic blemish of Duane's patients are these upshoots and downshoots. So they can be due to a mechanical cause or an innervational cause. So the mechanical cause is because of the very tight LR, which just slips under or over the globe, or vice versa. The globe slips up and down. And this is called the bridle effect or the leash effect, and it is a very sudden sort of movement. Sometimes it can be an innervational reason also, where there is some sort of an abnormal synergistic innervation between the vertical muscles and the MR. So here the movement is slightly more gradual. Now, the management of Duane's, non-surgical, all the measures, and sporadic types, you have to rule out congenital malformations which can all be associated. So, because we can never correct this paradoxical innervation, we defer surgery till it's absolutely needed. And preoperatively, a force reduction test to find out where the maximum restriction of contracture is really required. So if there is significant ocular deviation in primary position, markedly anomalous head posture, disfiguring upshoot, downshoot, retraction, you go in for surgery. So surgical options, it should be an individualized approach. What is the main problem in that patient you address? So the recessions are all performed. You can do medial, bimedial. You can combine medial rectus recession with an LR recession if there is severe co-contraction. You can try transposition, but ideally never go in for a resection. Don't resect the lateral rectus if possible. Then for upshoot, downshoot also, a variety of procedures are available, like Y splitting of LR. If it is an disinnervation, you can do a recession of the vertical muscles. The differential diagnosis has already been mentioned is very important, because if the child is very small, examination of extraocular movements is very tricky. So you should not miss out on an abducent nerve palsy or an infantile ESO, where the follow-up and the implications are totally different. So in a congenital abducent palsy, there will not be a globe retraction. So that globe retraction is very classic, and the amount of deviation is in the primary position is going to be proportional to the abduction restriction. In Duane, the abduction restriction is very great, but in primary it may remain ortho. Similarly, in infantile ESO, you have to somehow see that the eye is abducting and rule out that rule out Duane and abducent palsy. So the DDs are very important. Coming to the next special syndrome, which is Brown's, which is actually not as common as Duane's. Limitation of elevation in adduction due to mechanical restriction of the superior oblique. Again, mostly unilateral, slightly seen more in females. So it could be a congenital Brown's or an acquired Brown's. Congenital Brown's is because of a shortened or inelastic SO tendon or something wrong at the trochlear complex. Acquired is usually inflammatory. It could be a systemic inflammation or a localized inflammation, post-trauma, post-surgery, etc. Abnormal head postures, very common here also. You can have a chin-up, contralateral face turn. And the patients may classically complain of a click or a snap felt in attempted elevation in adduction. So, Brown's can be mild if in primary position and in the lateral gaze, the eye is remaining without any deviation, and the problem is arising only in the elevation. If in primary position it's normal, but in the lateral gaze itself, the deviation becomes evident, like in the right eye of the child, it is a moderate Brown's. And if it is evident in the primary position, you can call it as a severe type of Brown's. So always remember, the elevation is going to be normal in abduction. There won't be any muscle sequelae because it is not a palsy. But you may get a slight overaction of the contralateral superior rectus as seen in the picture. Mostly it causes a V pattern. Again, the FDT is very important. You should all know how to do an FDT on the oblique. And you should know that a retroplacement or pushing the globe with the forceps into the orbit will further stretch the already stretched out superior oblique and accentuate the restriction. So this is a classic question of Hess chart in Brown's. So the DD is again very important here. The DDs are inferior oblique palsy, where you get an A pattern. FDT will be negative, sequelae will be present, Bielchowski will be positive, and double elevator palsy, where abduction is in abduction also elevation is going to be restricted. So most of the Browns will spontaneously improve over time, and so we opt for surgery only in the severe cases. We can go in for SO weakening procedures, SO expansion procedures. Acquired Browns we manage medically with steroids, local injection or systemically. Just a mention of double elevator palsy, which is actually a misnomer. It is actually a monocular elevation deficiency. Video. Okay, so both in abduction and adduction, the elevation is restricted, and it is basically of the three types mentioned. Could be due to a tight IR, a long-standing SR palsy, or a supranuclear origin. So in adduction it is elevated. In abduction also it is going to be restricted, the elevation. So basically in DEP also the management depends on whether it is paretic or restrictive, and you can do, if it is restrictive, you can do recession along with vertical muscle transposition. So a variety of special conditions causing strabismus. To summarize, each syndrome you have to diagnose the syndrome, most importantly rule out the differential diagnosis. A force reduction test is of immense significance. The surgery is very challenging in these cases. A tailored approach, you have to find out what the maximum problem is and address that particular problem. Thank you so much.
Thank you, Dr. Gargi. You made it very simple and easy to understand.